Welcome everybody to a new episode of IG Life with Astrid, your APD. Today I have the pleasure to be having a great guest, Andrew Locke, and we're going to be talking about back pain, injuries, rehab, and everything in between. I'm just super keen to talk to you, just to ask a lot of questions about so many things we have to catch up on, because I remember we did an IG Live a few years ago, and I think it is well due to do another touch on injuries, back pain, and a few things that people wanted to know from the experts, and you are the one.
They've come to the right place then, haven't they?
Is it possible to start just with doing a little bit of introduction around understanding our spine and the back, and what is the difference between the spine and the discs and the joints, and how these things can easily get into trouble if there is a chronic position or chronic repeated movement that can aggravate or make something go wrong. How humans, we are so amazing that we can endure so many different movements, and like the spine and everything around the spine is so amazing. But what can you tell us about some of these important differences of, like, if we think about the anatomy of your spine, what are some of the things that you could talk to us about it to get us understanding the very important part of your back and back pain?
What a great thing to do. That's what I do all day. I have to explain it to my patients. And of course, because I run the Lumbar Spine Leadership Academy, these were a lot of questions people asked to begin with. Well, we can go right back to understanding what the spine does from an evolutionary point of view. So if we look at the lumbar spine, it essentially has evolved. We are the only primate that exists that has what is called a lordosis in our lumbar spine. That is the inward curvature. That's us. We're the only ones. Around about 4.5 million years ago, our first ancestor stood upright. Now, all the other primates that you will see on Earth at the moment, such as chimpanzees, monkeys, whatever you look at, they do not have that curvature in their lumbar spine because they are essentially what we say, walking on all fours most of their time. We had this evolutionary advantage for us that we started walking on two legs. Well, to walk on two legs, that means your spine is going to need a whole different shape to enable you to walk on two legs effectively. So here's us as this apex predator that we became, and we have essentially evolved the Homo sapiens spine around about 400,000 or 500,000 years ago. Now that spine has this particular curvature in it, the lordosis. But our pelvis had to change with that as well to enable us to be able to extend our hip in walking. So we've got this beautiful hip extension. I actually have a great relationship with a zookeeper down in Miami, Rudy Serrano. And we're doing a bit of a post on that as well because he looks after the chimpanzees. And we've done a little video on how the chimpanzees walk and how the humans walk. It's a bit of work to put together. But here we are, this upright human being that evolved to walk, run, climb. But we, in the modern society, sit on our ass most of our life. So the spine is well evolved for walking, running, and chasing prey. But it is not evolved to sit down in a modern society. So it's not an evolutionary failure of the spine. It's had no opportunity to adapt to the current modern lifestyle. The problems that we experience then relate to a hunter-gatherer spine that exists in a modern society. So the spine that should normally have this beautiful curvature in it then gets rid of the curvature and flattens out when we sit with 90 degrees of hip flexion. And now that changes the mechanics of the spinal structure because upright walking is very healthy for a spine. A disc doesn't actually have any blood supply to it at all. maybe the outer millimetre or so. But this huge structure that sits in between the bones does not have a blood supply. That means, of course it makes sense, it doesn't have a blood supply, nor does it have a nerve supply to the centre, or anywhere except for the outer couple of millimetres. Because you wouldn't want to be feeling what it was like to walk every step of the day with nerves in the disc. So the disc itself is relatively insensitive. Until you get to the point where you get to the last couple of millimetres. Then you might feel you've got a problem, but by that point, you've had a problem for a while, the degeneration process. So they don't just start, hey, my back is sore today. Well, it's probably taken you quite a long time to get to that point that you didn't realise. So a disc is not vascular, neither does it have a nerve supply. The bones, nicely vascular. In fact, the bones are really interesting. The bones are one of the few areas of the body that the veins don't have backflow valves. So normally veins have backflow valves to stop them flowing backwards. But if you weight bear suddenly onto a spine, well, the blood has to basically move out of the bone or else it would pretty much explode. So it's quite useful to have a vertebral structure there that doesn't have backflow valves. This essentially helps us with our weight bearing in our training. So we have the bones and we have the disc and then we have the next bone. That's just one segment. When you injure a disc and you got to the point where you've really injured it, and perhaps you have a disc bulge, perhaps you've had such a thing as an extrusion where the central material has actually come out, it will never return to the same state that it was prior to injury. It is a very different structure to any other joint in the body pretty much because it doesn't have that blood supply. So as a result, when you injure the back and the disc is injured, the healing up creates a whole different structure, reasonably like a weld. It's not the same disc material, and the outer part we call the annulus basically creates what we say is, it's a granulation tissue, not the same as the original tissue. Now, that will set up a cascade over time to which degeneration will tend to progress. A lot of people with back problems, when they get a scan, say from an MRI, the radiologist will write something and say, that disc has degenerative disc disease. There's no such thing, doesn't exist. There is no disease of degeneration, it's degeneration. So we remove that word out of there, it's the degeneration of the disc. Now, when I blew my disc up about 20 plus years ago, it was a very big injury. That took me 2 years to be able to even walk properly again. But now, here I am, about 20 years later after that, I have no disc at all that's left. It's bone, now I'm bone. It has fused itself. Yet in the process of that 20 years, I experienced zero pain while it further degenerated. Now, I do know what I do, so I'm fairly good at understanding how to make myself stronger and better. So there's not necessarily a relationship between the degeneration and what a person experiences. Big difference is, this is objective. This is reality. Pain is subjective. That's a personal experience. So the pain triggers will come from the structure, but the way you experience pain is going to be related to many of your social, genetic, there's so many aspects of your pain experience. Now, I'm not a psychologist. I'm basically a movement scientist. My work would be to identify what the trigger is that creates your personal pain experience and remove that pain, remove that trigger. That's realistically a big part of what we do. We look for the movements, positions and postures that are creating the biological trigger. There's a very, very hugely basically, let's say, social media is basically all misunderstanding. When you hear a dumbass, and there's lots of them out there, in fact, there's most of them out there in this area, who will say something like, there is no evidence of such and such. I'll guarantee you that the people who say that haven't read any evidence, and they don't even know the science. They're just parroting what somebody else said. The evidence about how a disc gets hurt, it's massive. It's been established for decades. I'll even pull one out. I'll find another disc for you. There we go. The 3 simplest ways to hurt a back. There's your primate spine. All right, the disc sits in between. It's a relatively hydrated structure, got a fair bit of fluid. It's like a thick, hairy jelly. Well, if you want to injure a disc and get a posterior disc herniation, let's make a nice one with this Chinese model. There we go. Got ourselves a disc bulge. How did I do that? Well, I flexed the spine, I put it under load, and that created the disc protrusion posteriorly. 100% of all the studies that have ever been investigated on the production of disc herniation show that's the mechanism. Yeah, there's lots of evidence. Hey, you ever heard of somebody having a stress fracture? Well, guess what that happens through? Bending backwards, and that's where the bone runs into the bone below, creating a stress fracture at that point there. Now, we have a fantastic universal biological term, we would say, or a motto. All biological tissue has fatigue and load capacity. Exceed the capacity, create injury. Not talking pain, pain psychology. It's an experience. We're looking for the trigger. So your 2 major ways to create the injury at the disc or the spine is your flexion under load and your extension under load. There's your cricketer who's fast bowling. There's your tennis player who's serving. Easy. That's how you do it. Or direct compression straight down can fracture the top of the bone, what we call the end plate. 3 mechanisms, and guess what? Physics says that's what should happen as well. So I found out that pretty much no university in the country actually teaches that to their poor graduates in pretty much any health science. Doesn't matter, chiro, osteo, physio, medical professionals. It's shocking they can spend all those years at university when really it just took me probably 10 minutes to explain exactly how the body works and how the injury is produced. It's not tough. It just takes...
I do have a question. Okay. Why the majority of the back injuries would happen always around the lumbar spine and not higher?
Well, most of them, that's right. So here you have a hunter-gatherer. I've actually got a good model here. These models are actually made from cadaver bones by a friend of mine over in Canada, Dynamic Disc Designs, a guy called Jerome. He makes the world's best models. So there's your pelvis and lumbar spine with this lovely curvature. Now that's your hunter-gatherer. Let's sit that hunter-gatherer in posterior pelvic tilt. Oh, you can just see where the loading is occurring, down at the lowest lumbar joint. So when the pelvis flexes into posterior pelvic tilt, the spine must also flex. So now you've got the flex spine with the body weight above it and the posterior pelvic tilt. Well, how resilient are we that it takes as long as it does to actually hurt it anyway? Seriously, most people start sitting when they start in kindergarten. They sit in primary school. They sit in high school. They probably sit during university. They sit for their jobs. It takes quite a few decades. That shows how resilient that strong structure is underneath. And of course, a person does one of 2 extremes. They do a deadlift with further lumbar spine flexion under load, and they've finally got that last little bit they've injured, or they bend over in the morning to pick up their sock. The load has taken probably decades to achieve that point. But now the rehabilitation has to bring you back to being painless and able to load again perfectly. So I deal with athletes who lift well into, some of them, 500 kilogram squats. So many of them I deal with had 400 kilogram squats and deadlifts. And you can rehabilitate those people even when they have had the injury back to total weight bearing capacity. So although the structure doesn't necessarily have to return to its original state, which it won't, the ability to load and weight bear can be returned and improved. So one of the great injuries of all time probably happened to a guy called Brian Carroll. Now in 2009, he experienced such a beautiful spinal injury, nice disc bulges, fractured his spine down to the sacrum. Yet I think it was 2020, he squatted the greatest weight ever squatted by a human being, 1,306 pounds. So there's a guy, humongous injury, years of pain, yet rehab correctly, then broke the world record that's still set, 1,306 pounds. So the injury does not predict your future.
A follow up on that. When you think about the back pain, which even though it can be psychological and socio-psychological, and there's a lot of different things that can trigger actual pain, pain is going to obviously be part of what limits us to move, to kind of get back into movement or doing rehab, doing anything that involves or triggers the pain. So what are your best recommendations when it comes to dealing with a back injury? Going through the pain, is it requiring to use a lot of painkillers and anti-inflammatories at the very beginning to being able to get through the pain? Is it better to not do anything? How much exercise or movement is too much, especially in the early stages when you have a lot of inflammation in the area? This is very aggravated, because I remember when I had a really back pain back when I used to run a lot and there was a lot of impact. There was a point that I felt the pain, but it was no longer an easy pain. It was actually debilitating to the point that I wasn't able to stand straight. I wasn't able to bend forward or extend my back without having sharp pain all the way through my back and my sciatic nerve pain. I had so many different things, and I tried to ease the pain. I did massage, trigger point, stretching. I was trying to do everything at once, and I think it actually aggravated it more until I had to completely stop everything that I was trying to do to solve the problem and just let it go. And I had to stop doing exercise, trying to stretch it, trying to do things. I really need to stop. So I think in summary of what I want to ask is, what would be the difference between acute and chronic pain, and how do we get on top of it to heal it or to reduce the pain from when it starts to managing it over time to the point that you can actually live with it and thrive through it?
What a beautiful question. And I think it's one that has not ever been answered that well very often. Okay, let's go create ourselves a nice disc bulge. Let's do an acute one, huh? There it is. Got our nice acute disc bulge. Yes, the first stage. The first stage is you now have a disc that has not got a competent wall. It's got a little breach to that area. That disc material, if it's there from the nucleus, that's actually quite inflammatory. And you're going to go through an inflammatory phase, and that irritates the nerves in the area. There is not a mechanical process at that point, very much, unless you're very experienced to play with it. But there's no doubt you have to go through the inflammatory experience.
Mm-hmm.
Now that, in a common sense, might take a couple of weeks, where now the material there is no longer irritating the nerve root. You have to pass through that inflammatory stage that is produced by that injury. Taking anti-inflammatories? Yeah. Taking painkillers? Yeah. Remember, I have this wonderful, shall we say, distinction between two things. Pain is just a measure, but it is not what I'm actually treating. I'm treating the injury and the injury mechanism, and I'm using pain as a guide. So I don't treat pain. Pain is a guide to whether we are doing the right thing. Now,
Okay.
you've got that nice fresh disc bulge. When muscles contract, there's some bones there for you. When muscles contract, they produce compression. Now, if you've got a nice disc bulge that's just relatively fresh, then that disc bulge will not appreciate compression. A very common one here is people, if they lie flat on their back might hurt, but they put their legs up on a couch, bent up at 90 degrees, and it doesn't hurt. All we've done then is we've actually taken the psoas muscle off stretch. So when a person lays down flat and they've got a back pain or a back injury, the reflex mechanism actually tightens up the psoas, which then produces spinal compression for the purpose of stability. Now, an intolerant disc doesn't appreciate that, so we find a position that allows it to be tolerant to compression. Now, that's when you started running a bit later, you were not compression tolerant. That's what you're missing, compression tolerance. But maybe you could walk, but when you increase the velocity, you increase the compression. So we have a stage there which we can manage by understanding what compression was doing. There's three components to spines, only three. There's only three directions humans move. People are learning more here than they actually learn at university already. A human body only moves in three directions: forward and backward, one direction; side to side, the other direction; and rotation. They're the three planes of human movement. Now, if you want to jump and do a dunk in basketball, all you're doing is you're applying forward-backward motion to the ground with force to get the ground reaction force that propels you upwards. Three planes of motion. Now, we have three planes of motion, and the spine's actually really good at that. The lumbar spine, now let's find ourselves some joints there. We've got some nice joints in there. Good. You'll see the joints are very vertical. So the lumbar spine flexes and extends forward and backward because that's what the joints do. They allow a little bit of side-to-side movement, but guess what? They don't rotate. There's no rotation at these joints, or should we say, so minimal amount. And that's the way our spine is essentially evolved, because we bend over, pick things up, stand up, walk and run, straightforward plane. We do our side-to-side motion, but our rotational movement actually really comes through our thoracic spine and our necks. Three planes of motion. Now, if we're doing assessment, and this comes up really from a fantastic guy called Robert McKenzie, who made a discovery in 1957 in a clinic that allowed us to understand how movement could be analysed. A whole series of work came after that, and it's all been correct. Three planes of motion, but there's also three components to the body. Passive structures. Bones and discs, you can't contract them. They're passive. You can't contract bones and discs. Muscles, you can contract. They're active components. So you've got passive components, active components, and then we have the nervous system underneath and the brain, which controls the motion. So you've got active, passive, and neurological. Three planes of motion, three components to evaluate as far as the body goes. Great concept, and well, it's like the theory of evolution. It's called the theory of stability by a fellow called Punjabi. Now, if you have an incompetent passive structure, such as your anterior cruciate in your knee, you don't need surgery. You learn how to stabilize your joint through the musculature. You use active muscle through a neurological system to control what the passive structure used to do. So there was your rehab, Astrid. Early stage, inflammatory, intolerant to compression. Then you start to become tolerant to compression. What do we got to do now? We must create the active system to maintain the segment that is aggravated through certain movements. Welcome to the first stage of rehab. First stage of rehab, settle the passive structure down through movements, positions and postures, such as you probably didn't like sitting for too long. And that was increasing the flexion of the spine that produced the injury in the first place. So we minimize the sitting. We encourage some lying down the front normally. We encourage some extension. And in the right time, in the right place, that encourages the disc material to actually return. That's been well proven in studies as well. That's the early stage. Now, you've influenced it passively, you better influence it actively, and that's where we have our core stability. The word's overused. In fact, I've actually got the book that the word core was first used in. Famous guy called Bob Gudger, who was a coach back in Chicago, wrote a book, and he was the first person to actually term core stability. Now, core doesn't mean just your abs. There's at least 12 muscles we're going to include in that. And you have to make your active muscular system control the segment. First thing you're going to do is you're going to control the neutral. So you've got your passive structures through some passive intervention. Then you got to do active intervention. Remember, your psoas here is trying to stabilize you and it's doing a great job of compression. But what happens when a muscle turns on in one direction? What happens to the opposite direction? So if you flex your bicep, what happens to your tricep? Your tricep becomes inhibited. So in a person who's got facilitated hip flexures, guess what? You better start facilitating your hip extensors. So a big part of the rehab process is, yeah, you're going to do your core stability, but you're also going to be doing glute work because you need to decrease the facilitation of your psoas. Hey, guess what? That just decreased your compression as well. Now life's looking good. So stage number one, yeah, you want to be able to get a good neutral position, well controlled. Stage number two, return to activity. And that could mean you end up doing Jefferson curls one day, if that's your sport. But the disc is never adapting positively to flexion loading after you've injured it. It is not the same. A lot of people use this thing called Wolff's Law. That means they don't even know what the hell they're talking about, because Wolff's Law is only related to the femur of juveniles and how the trabecular bone actually adapts. It's got nothing to do with the spine, and it's got nothing to do with bones outside of the femur as far as Wolff's Law was concerned, and it's certainly got nothing to do with muscle. So discs are not under Wolff's Law, and muscles aren't either. How interesting it is. A very misused term, usually by the people who say there's no evidence, because they're so dumbass. They're like kids who have counted up to 10 and think they know all the mathematics that exists.
When we're thinking about doing rehab and pain or identifying pain, how often do you observe when you're diagnosing a patient's injury or a way to rehab the injury, that your body is all connected, and like an issue, a chronic issue or a chronic poor movement or something in your shoulder or in your ankle can actually make your body not balanced enough to in order to, so it ends compensating in a way that continues to function and show you that it can do what you're asking it to do, but obviously it's not going to be the most efficient and the most appropriate way to do it naturally. Your body's compensating with other parts of your body. Your spine is adapting, your muscles are sort of trying to work, and it creates like chronic imbalances that at the end of the day can create back injury or back pain. Like I remember just having a motorcycle accident, and I have an issue on my left foot and also on my right foot because of the accident. I had a small fracture, and I obviously was not able to walk properly for a while. So I was trying to kind of compensate to stay upright, to manage walking fine, but I kind of like identified over a few months later that I was getting more pain, back pain exacerbated when I went onto long walks, or when I was actually doing things or exposing my body to a same run movement pattern for repetitive times, for a long period of times, versus when I wouldn't do the same movement for a short period of time. So again, just to kind of summarize my question, how much is true that our body can compensate, and one thing on one extreme of your body can actually create an injury or pain somewhere else, like in your back. If you have an ankle injury, shoulder, something that was potentially you wouldn't even cross your mind as totally unrelated to your back, but somehow it does affect your back and alignment of your back and things like that.
And it makes so much sense. Here's the beauty of where we can start to realize people don't, especially the social media world out there. The problem is a lot of people don't realize the spectrum that's related to it. Because you know who the fastest runner in the world of all time was, or is? A guy called Usain Bolt. Usain Bolt has one of the most significantly bent spines you've ever seen. He has a huge scoliosis, sideways curvature of his spine. He has one leg that's about 2 centimeters shorter than the other leg. When he runs about 60% of the time on one leg and 40% of the time on the other leg. Welcome to one of the most unbalanced humans you'll meet as far as structure goes. He also happens to be the fastest guy on earth. Why can't you do that? Well, one of the relationships there is he grew up that way. So his ability of his spine to have actually adapted through youth all the way to adulthood means he's got a different relationship to you when you have not got that disability, but your injury causes you to be changed in your relationship. So your structure hasn't been used to being unbalanced, uncentered, and you're going to more likely then experience the feedback from your body that that's not pleasant. So there's the relationship between having had something significant and growing through it as in something new. There's a great example back in baseball history of a fellow called Dizzy Dean, one of the great pitchers for the New York Yankees. Dizzy got hit on the foot by a ball that was batted back at him, and it broke his toe. Dizzy, back in those days, pretty tough guy, probably tightened up his shoelaces, continued to pitch afterwards. It wasn't long before his career was over. His elbow injury came out. He'd never had an elbow injury in his life, but changing the mechanics of his step to release the ball changed the mechanics at the elbow, and that was the end of his career. Over. So yes, if you have something that can influence another structure, it can relate to producing an injury if the load and capacity is beyond what it can take. Of course, throwing a baseball, at such a high velocity and throwing curved balls, well, that takes a lot of elbow control. And of course, here was a situation where it changed those mechanics just slightly. So yeah, that's where we evaluate the individual every time. The individual has to be evaluated. And that's where you get a lot of people on social media who actually don't rehab athletes. There's so many out there who put themselves up there as experts, and you look at it and you go, yeah, who have you ever actually treated? Well, they've got nobody. They've been in the industry for 20, 25, 30 years, and all they've ever done is talk about what the research says, but they've never actually rehabbed a top athlete. So when those sort of people, when you look at somebody who proposes they are some form of expert, find out who they have ever treated and brought back to top level sport. Now, my work is all clinical. I've done my research work and I continue daily. But yeah, I've got 2 400-kilogram squatters and deadlifters I will have worked with this week. I've probably actually talked to 3 of them. I work with people who are actually success stories. Now, look at your people who say there's no evidence or the data says, yeah, tell me what your patient's outcome are, mate. They've got no patients. They don't successfully rehab anybody, but I'll tell you what the evidence says. I say the evidence is showing that you actually can clinically work with a human being and understand how individuals move. That's the people you follow, people who do have great research backgrounds, and also, guess what? They apply them every single freaking day. And that's all I do. Yesterday, full patient load. Fantastic. Had some really interesting ones. Now, my ability to apply research to clinical individuals is what really success is all about. So it's a real evaluation. It's a human experience.
A little question that just came out. I'm sort of processing your answer, and then it's like bing, a question that comes up. So, how much do you rely or believe on MRIs, X-rays? How true or how much information can that actually give you when you're assessing a patient or a client that is talking about a horrible back pain? They have been having that issue for a while. How much information truly you can get with an MRI or like these tests that show you what is happening in your spine at that moment in time on a specific position where you get assessed to get that image? But how far or how close is that to the reality of deciding whether that is a complete full diagnosis that you can have based on an MRI, or whether you decide, hey, I'm not going to even look at it. I just want to be here with my patient, look at how it moves, and try to diagnose based on their movement patterns and the pain responses.
Yeah, exactly. So in 99% of the cases that will come to me, they will come to the practice and they'll have their MRIs and their scans. And usually the first thing that happens is they try to pull them out. And I just say, put them in the corner, we're not looking at them. Because I must assess you first. I must assess you with a very, very clear mind. I don't need to be biased by thinking about your MRI before we talk. So the important thing is to do your assessment prior to actually looking at the scans and the reports. I had one yesterday, same sort of thing. Comes in and I said, put it away. He moved, he told me his problems. I said, okay, so you've got an L5S1 disc bulge to your left. And he goes, yeah, that's what the report says. I said, all right, so the report's right. I don't need the report on most people. I don't need to see the scans until after I've finished. Because then we can start to realize what influences that those scans may have on our planning of the protocols that the individual undertakes. So if I've got a person who has a spondylolisthesis on the scan that is significant, but they actually have an active disc bulge and they're not symptomatic of the spondylolisthesis, then although I will be treating the disc bulge and finding the directional approach that will solve the issue, when I'm planning a protocol for the future, I may be very much aware that I'm going to limit their lumbar extension influences later. We may use them earlier, but I'm going to consider that for their long-term outcome because of the structure. So the scans have their value. Now, I've got a patient, I'm heading over to Europe for at least a week or two to work with a VIP. Now, on that individual, I can allow myself the opportunity to read all the reports through those individuals before I see them, because I'm only focusing on that person, and I am able to spend a lot of time evaluating my expectations, and my opportunity to treat them is going to be a couple of hours. So it's not going to influence me before I get there. It gives me information that may help me understand them. So there are the rare exceptions. I will assess beforehand with a scan, but it's almost never. Just depends what level and how much time I've got to work with a person. Scans are useful, but they're not telling you what to do. Your assessment's telling you what to do.
Okay. Now, when we think about these different exercises and movement patterns or sports, would you say that are there more injuring movements or sports than others? Like, let's say, it always, I think I know your answer, but I'd love to hear from you. What is your stance on like trying to live longer without pain or minimize injuries? If you can choose your training and movement patterns, let's take away the sports that can be very specific and more so the general population that goes to the gym and trains the body, goes and do different sets of movement patterns, deadlifts, squats, machines, free weights. that other type of movements. Where do you stand when it comes to selecting movements and loads and repetitions and volume when it comes to longevity, reducing the injury risk or reigniting an old injury that is probably there but it's not causing you any pain right now? It's just no issues whatsoever, but you just want to be smart about selecting what is going to be safest for you being able to show up to the gym until you're 90 years old.
Very good, because every person's goals, it's one of the first things I ask a person is, the first thing is, what's your problem? Because I make sure that they don't say I've got a disc bulge, because I'll tell them that's not their problem. What's the problem you're experiencing, not the diagnosis? The next thing is, and what is your end goal? What have I got to get you to? So we bookend our approach, which is, what are we dealing with now? What have we got to get you to at the end? So I've got a fantastic world champion who I worked with recently, excellent human being, and as he said to me, I'm not pain-free. And we've worked for quite a while, he's doing really well. And I posed him the question, I said, and when was the last time in your life you were pain-free? And that perspective made him laugh, because he hadn't been pain-free for 20 years. His extremes in his sport, NFL, American football, and weight training, required that he existed under high load conditions and high performance conditions, that there was some manageable pain in his everyday life. He was not expecting to be pain-free. So when we got down to talking about, you're not painless, have you ever been painless? Good point. What I'll actually say, Brian Carroll there again, there's our biggest squatter of all time. He actually says he's pain-free at this point in his life and has been for quite a few years. So you can be pain-free. Matt Wenning, who's a fantastic coach and individual I've worked with, Matt I think he's got a good perspective where he said, when you're working with high performance and you have a high performance life, there will be a cost later down the track in regard to having done that. Matt talks about his kidneys. Now, he's very much aware that after 20 years of being a super big guy, carrying super big loads, and blood pressures that you would not imagine that he's had to deal with, he had them measured, they were out of control. They were controlled during the lift, but they were humongous. Now, he looked at that and said, okay, well, I've had all my tests and my kidney function's not as good as it should be. He also relates to the fact that was the cost of all the things that he had done to get to that point in his life. And that was a good perspective for him to make was, how many great athletes do you see in performance sports such as basketball and football and things like that that are still in their 40s? About none. Because you use a lot of certain capacity up and your body's abilities in those ages. The body ages. It changes. The collagen gets stiffer. Now, you want to be a world champion powerlifter, you can actually go a lot longer. In fact, I've got a guy who's like 62 now who deadlifts 300 kilos and squats 300 kilos. In fact, they're his PB's all-time life, but he's 62. Well, powerlifting in itself can be a forgiving sport if you're very technically good. It's a little less forgiving as the loads increase for time. So I'm currently dealing with a couple of those people right now, preparing for attempting breaking world records. Now, there's a point to which some of them realise we're working close to the edge, but we're prepared to do that to try and break the records. But we're not expecting we're going to do this for 10, 20 years. So a person who wants to live a normal life, they can do it quite well. Their body's very resilient, very adaptable. It's about being smart in the gym. Do you need to do a 1 rep max? Really? Why? Perhaps you just work with beautiful movement patterns and acceptable, strong loads for what is a good human being. I've heard a nice approach saying all people should be basically capable of doing a deadlift with double body weight as an acceptable outcome that's not extreme. Well, Deadlifts sometimes have to be modified to the individual body, so they're not all the same. The bar's 9 inches off the ground. It's not right for everybody. Sometimes you have to lift it a bit higher. Sometimes you have hip structures you have to deal with. But the movement itself is a fundamental thing of picking things up and putting them down. It's a good movement. So yes, the general human movements, squat, deadlift, running, climbing, they're great patterns for overall health. It's really common. Find out how many people can put their hands straight up over their head. When you find the older population, how many of it's very interesting, can't get overhead with both hands. They've just got stiff in their spines. But it should be totally restorable if you start to teach them how to achieve that. So good health can usually be improved for everybody. It just takes smart programming.
When you say, are there any recommended exercises that you will most likely do, not daily, but relatively consistently on a weekly basis, to ensure that we are including movement patterns that are going to ensure longevity? Let's say something that relates or simulates putting something overhead, something bending forward, something squatting down in order to reach the toilet when you are 80 years old. We're trying to think about movement patterns that simulate real life, but the way to train them and train this effectively and and teach the function right would require to have awareness of it and put it in place in early stages, so there is no decondition of those muscles or movement patterns, so they allow you to move right and well for these basic movements that pretty much represent our daily life movements.
There's a really good process there. I could bring it down to 2 basic things every human being should do all their life. Number 1, lay on your back and get off the ground and stand up. Now, you should be able to do that without it looking like a tortoise on its back in the sun. In other words, a human being should be able to get off the ground and stand up relatively easily without pain or dysfunction. Well, is there an exercise we can even strengthen that with? Yeah, Turkish get up. So if every human being, for me, the get up's a beautiful movement. It's a fundamental movement. In fact, there's a beautiful study that was done in Brazil, and it's been replicated quite well, that your predictor of mortality with older populations can be calculated, your statistical likelihood of mortality, in your ability to get off the ground into standing. And there's certain markers there which we take points off for. Now, you got to try and minimize those. So there it is. There is actually evidence that if you can't get off the ground effectively and efficiently in an older population, you have a greater chance of mortality in the next 5 years than the person who can. Well, there you are. You got some longevity now. What's the second thing a person should do? Walk, and I would suggest be able to run. Okay. Because that's what your spine was supposed to do. You must be able to walk, but I would like you to at least be able to get a nice jog in. If you jog and you do a Turkish get up off the ground, you're doing the 2 probably most fundamental things that will give you good health. Above that, yes, some weight-bearing work would be really nice to perhaps combat osteoporosis. Mm-hmm. So lifting movements, quite effective a couple of times a week. I work with some older patients, and we could say quite happily up to 90 quite often. And all I would have to do is say, I want you to buy a 16-kilogram kettlebell. I want you to lift it 10 times. I'll show them how to do it in a deadlift style. Now, if you just lifted 16 kilos 10 times, you've just put 160 kilos of volume load through your body. Let's do that 3 times a day. Now you've done 480 kilos. Imagine what that does to you over a week. Imagine what that does to you over a month. Yeah, simple tool. Apply some load to the body, do some repetitions with it, and it will accumulate.
Are there movements that wouldn't require load that you recommend for improving alignment, posture, better mobility? For example, I see a lot of physios and like overall recommending for longevity certain movement patterns like ankle rotations, shoulder rotations, forward and backwards, mobility of your scapula, things around your glutes, strengthening your glutes. Are you someone who recommends or feels like these rotations and mobility through some of the most important joints will have any impact in longevity?
Absolutely. In fact, there's a beautiful one from the head of the Russian health department many years ago. He'd be dead now. His name's Amazov. He's a general in the army who became a cardiac surgeon. And he had this wonderful recommendation that every joint in your body should be put through its full natural range of motion every day. He had an approach which said you should do 1 repetition per year of age. Now that means by the time you're 80, you're doing a lot of repetition work. But he moved wonderfully and youthfully well into his later 80s. Now, the thing is, he's spending a lot of time on his mobility to enable him to move that wonderfully. But that's reasonable for a person who wants that health outcome. Yes, you'll move better if you make sure every joint has its full range of motion every day.
If you were to recommend joint mobilities, meaning around your ankles, around your shoulders, hip rotations, once a week, every day?
Every day.
How often and how much?
Well, it depends on your age.
Yeah.
Younger, you don't need to do so much of it, but you do need to start increasing it with each year of age. Now, I would like to say most people should probably start looking at that as a habit in their 30s. I get people who come in who are well and truly 50s, maybe 60s, who I can still restore to full natural range of motion if they haven't had a huge injury background, because that may have affected some loading changes. For example, a spine that's getting a lot older, what we find is that most of the disc heights will have some decrease, and we'll find some arthritis in the joints here. That will limit some motion. We work within those understandings. So you can't restore something that has a structural change to it, but you can optimize it.
Okay. Now,
optimization's it.
Talking about hip labrum tear, and what are some of your recommendations or solutions when it comes to doing exercises in the gym? As someone that really likes, and part of their feeling good is still heading to the gym, lifting weights. That's part of their lifestyle. But now there is this labrum tear that is just giving them a lot of pain and issues. What can they do about it? Are there exercises that you wouldn't recommend? Are there exercises that you would be more likely to recommend for this person to continue moving through their training without increasing pain or inflammation, or even reduce it or heal it?
I've actually got a human leg bone over here to go with this pelvis. I'll have to show you. Hold on. I have to go get myself a bit of a body. I got a few skeletons in the house, part of the medical background life.
Amazing.
Oh, that'd be fun. Yeah, no, got someone's bone. Make sure I got the right one. Well, there you got yourself a hip now, right? Now, most of the really top performing athletes I might deal with will probably have a labrum tear, but they have zero pain. The labrum tear will have occurred somewhere through performance, but the labrum's not going to repair itself. So we have to find out, can we allow the body to move well and not aggravate where the tear may be? So most human beings, instead of being that wonderful upright human being, there we have our hunter-gatherer walking along, using that nice big glute to move the leg backwards. Most people are doing this. There we are. We're now sitting in a chair. Well, that's more likely to close down the front of the pelvis, the hip joint there where the labrum is. Now, walking will enable us to use our gluteals, which will centralize the hip joint better. So you could have an anterior labrum tear quite nicely. But if you do good hip extension work, concentrating on the gluteals into extension, most of the people I would work with, that in itself would be a solution that will resolve their hip pain. Daily gluteal work that has an emphasis on the extension of the hip, because glutes work in three different directions, the three planes of motion: forward, backward, side to side, and rotation. But we may be looking at focusing on the extension component and maybe having to recruit the other two components with exercise to enable us to extend better. Just an anatomy. So yes, labrums do not in themselves cause you to have pain unless you are continually aggravating them.
Would you recommend any, if you were to recommend 3 or 4 exercises to do that allow that hip extension or hip mobility to reduce the pain, what would be your top 4 or 3?
The first start must be the person should be able to lie face down on the ground with their knee bent and be able to lift their thigh off the ground a centimetre or 2 without the pelvis moving. Now, you're going to get a lot of stiffer people out there who can't even lie face down on the ground and have their pelvis on the ground. You're going to put a pillow under that person's hips, accommodate to the fact they haven't got that normal range just yet. And we work on the hip extension movement. There it is. We've just regressed hip extension to a bit of flexion as well.
Okay.
Over time, let's remove that pillow and get a person flat and be able to extend the hip without the pelvis rotating and the spine extending. Now, if you can do that, then you just set up the fact you can actually walk correctly. And walking then is going to be using your gluteals better into extension. And that's going to be healthy for the hip. A hip bridge movement. Excellent. There you are. You're going to lay on your back. You're going to perform a hip bridge movement that is bringing hip extension in. So my motions there would be to be able to have hip extension and a hip bridge. Perhaps at this point we might add a load to it. We can introduce a hip thrust. Now the range should be such that you're feeling it's capable and not any aggravation. Now I'm emphasising very much there strengthening the hip into extension. So there's your basics. Face down, get extension, then lay on your back against gravity, get extension, and now put a load onto it and you'll grow your glutes. And your labrum at the front of your hip, you're probably not going to hurt anymore. Nearly every person who's ever come to me that was told that they needed a hip replacement has yet to have one after they instituted the right exercises.
Do you always recommend more unilateral work or bilateral work?
Initially, unilateral is going to be great with the prone face down hip extension. And we'll do the bilateral movement when we move into the bridge, but you can bring that to a unilateral movement if you wish. There's a nice progression. So you progress from the bilateral to the unilateral, and certainly walking and running is unilateral. That's a human being being restored back to natural function. And it takes the appropriate progressions to know what to do. That's all it is. There's no such thing as a bad exercise. There's just the wrong exercise at the wrong time for the wrong person with the wrong load and the wrong frequency. Exercises in themselves, they're not good or bad. All depends upon the purpose you're doing it. So there we are. Some nice basics there. Everyone now knows far more than pretty much mostly graduated professionals who are out there just by listening to that.
You're amazing.
Oh,
It's so great to ask you questions and being able to sort of like bring these to such an amazing level of explanation that like I really appreciate it.
tell me all. Let's try some more questions.
Okay, well, I've got one more question for you. So the one, how to find the right hip position for your body when it comes to doing the right form for deadlifts?
Beautiful question. Lucky I've got my thigh bone here, huh? The word femur, actually, I think it comes from the Latin, which just means leg. And there's the place that it sits into. That's called the acetabulum. That's from Latin, meaning vinegar cup. So that's what it must have been like in Rome. That must have been what a vinegar cup looked like. Finding a right position as far as a deadlift or even a squat goes, it relates to that structure there, that pelvis, that hip joint there. Now, quite often, some people have very tight hip joints. They don't have much movement outwards. But other people have nicely wide hip joints. It's a bit genetic. Scottish, Irish, Celtic hips tend to be tighter. They also, as far as I understand, have more hip replacements in Scotland than anywhere else in the world. They have the tightest hip structure and they have a high incidence of hip replacement. Whereas I believe Poland actually has one of the best hip structures, very nice shallow hip structure, and they don't have that issue. Now, when setting up a squat or a deadlift position, a lot of it depends upon a series of your lever lengths. Now, your hip structure will determine whether a sumo position is better for you. That's a big part of it. But your arm length is going to have a lot to do with it. Your torso length will have a lot to do with it. If you look at some of the greatest deadlifters in history, they can all stand in front of you and with their middle finger, they can almost scratch their knees. Okay, they have not only got what appear to be very long-looking arms, they also have fairly short torsos. So it enables them to get a very nice position, often quite conventional. But also, if they have great hip structure, they may be able to do a sumo from that position. Conventional or sumo, neither is good, neither is bad inherently. But one of the ways I tend to work on is, and it's very straight and quick, is if you put a person to sit on a bench and they have their legs in front of them sitting down, how wide can they place their feet and still keep their knees over their ankles? Now, a lot of people go, oh, that hurts. Well, guess what? That's as far as your hip structure goes. So you don't try and go beyond that.
Okay.
Some people can go wider. And that's a nice test. You can put a kettlebell on the ground between your feet and practice the different positions and find the one that really flows well. That's a simple one. We do have to shoot a video. I think we've got a video shot on that somewhere.
I'm sure you have plenty of resources in your page, in your Instagram, and so many amazing explanations. I am sure people can go and have a look at them, and or even if you have anything specific that we covered today, you can put it on your stories so people can go and easily find them. Andrew, thank you so much for your time. You're amazing. You are
pleasure.
incredible.
What we love to do is that we love what we do. You love your work. I love mine. It's a passion that drives us on, isn't it?
Absolutely.
Always.
Have a beautiful day. Bye.